Thank you, Dr. Anaga. And are my slides visible?
Yes.
Thank you. Thank you, Dr. Chitra. Of course, rest of my ARC team, especially for including neuro-ophthalmology overview in this discussion. And neuro-ophthalmology is not something which teachers, trainers, hospitals, large institutions are actually still focusing on. So it's really nice that we are actually bringing this forward for discussion. So I'll just talk about specialty brainstormer session neuro-ophthalmology overview, which is very important. So part of the residency training program, neuro-ophthalmology becomes important because it's a rather recent subspecialty that is now finding its place among ophthalmologists. And we realize there is an increasing need. Particularly, this has come in COVID times when you see this Journal of Neuro-Ophthalmology, and this list continues over 2 pages actually. These are all the reports of neuro-ophthalmological disorders which may or may not be associated with COVID, but are presenting now with COVID-related, in patients who were COVID positive or are COVID positive, and even some after various types of vaccination. So we know that the neuro system is particularly involved. We know infarcts, we know inflammation is happening, we know autoimmune antibodies are being formed, and we know many of neurological and neuro-ophthalmological diseases are related. So we probably are going to see an increasing need of the neuro-ophthalmology specialty as we go onwards in managing these patients. Neuro-ophthalmology forms actually a cusp between ophthalmology with various branches like medicine, immunology, neurology, pediatrics, and radiology. And it's actually a combination or interaction with all these specialties that we actually can practice neuro-ophthalmology. And that's why it becomes very important for residents who are being trained in multi-specialty hospitals to get an idea of neuro-ophthalmology so that they can manage these patients better. There are some very specific goals that we follow as we train in our hospital children or residents in neuro-ophthalmology. So there are very specific goals and objectives. So it has to be very specific patient care related objectives. There has to be a baseline overall medical knowledge, interpersonal skill and communication, because you realize that in neuro-ophthalmology, history taking an examination is probably the single most important step towards understanding the disease. Professionalism in your approach, so realizing what you know, what you don't know, what you can achieve, and what needs more interventions. Systems-based practice, and again, practice-based learning. So these are all specific goals we follow. The important disorders that residents need to be discussed about is particularly disorders of the visual sensory system. So optic nerve disorders, very common, various kinds of disc edemas that present, neuropathies that present, toxic, hereditary, nutritional. So in India, there are almost 25 lakh patients who are being treated on ATT. And with the new ATT guidelines increasing, ethambutol has a role to play. And therefore, we probably may see a lot more toxic. So recognizing them, stopping ethambutol and intervening at the right time can actually save a lot of patients from going blind. Chiasmal problems and post-chiasmal visual field loss. So field loss, understanding and localizing lesions become important. Ocular motility assessment is a key skill set for residents to identify ocular motility, nerve palsies, identify supranuclear problems, and even myasthenia gravis, which can be missed and is a great mimicker. So important that these skill sets must be imparted to them. Pupil examination is a very, very sensitive investigation for optic nerve assessment. And it's a very, very simple way to assess. So that's why it's extremely important that resident training should have these skill sets imparting to these students. Disorders of higher cortical function. So a lot of functional or malingerers can be identified, and increasing stress is responsible for many of these actually having a physical manifestation of a psychological problem. Nystagmus, trauma, manifestations of ocular and neurological trauma, tumors, intracranial pathology, intracranial hypertensions, infarcts, all these present often to an ophthalmologist first. So it's important to impart these skill sets to students, and of course teachers and trainers and ophthalmologists who are training these or giving imparting skills. It's important for them to be sensitive towards informing the resident about these issues. Headache, very, very important presenting history in a bulk of patients coming to our OPD, especially in these times. How to differentiate ophthalmic from non-ophthalmic, how to identify cranial causes, who to refer to, ENT, ophtha, medicine, neurology. So a differential of headache is important. Systemic disorders with ophthalmic manifestation. So these are again another set of problems which need to be identified. You need to identify how to take visual acuity, color, contrast, stereo acuity, the basic visual functions in every patient who comes. Visual fields by confrontation and, if required, static and kinetic perimetry, motility assessments and alignment with saccades, pursuits and reflexes, pupil size and reactivity, and stereoscopic assessment. Even if you don't have good tests, even a basic bedside stereo assessment is possible. Specific skill sets that need to be emphasized include gross neurological evaluation. So we all learned basic neurological assessment, cranial nerve evaluation in our MBBS. Need to just reiterate them that it is important in patients who need this or who have neuro-ophthalmological problems to get a baseline neurological assessment on their own, systemic assessments, and be able to examine a child and look at his developmental milestones, his levels of maturation of the visual system. These are very important that give us understanding of what the disease is and how it is progressing. Understanding the role of the various ophthalmic instruments, fields, electrophysiology, ocular and orbital ultrasound, OCT angio, and fluorescein angiography. These are all the tests we are using. Nothing new. All ophthalmologists know about this. Many institutions now have most of these tests. But that neuro-ophthalmic perspective, I'll just tell you, optic disc brucin on an OCT, very easy to pick up. So pseudopapilledema is very easy to pick up and identify and not have the patient undergo a lot of tests. Papilledema, true papilledema, now various tests are available. You can just see on the OCT and easily pick up true papilledema by the high level of spikes that you see, the edema that is there in the below the retinal layers, the angulation change, the Coppersmith angle as we call it, the bending of the sclera because of the edema behind, the OCT pictures showing very thick RNFL, yet the GCIPL showing thinning, progressive change, showing loss of function. And despite there being edema, you can see that over time, the nerves are getting atrophic. OCT angio can help to differentiate between NAION papillitis and papilledema. And of course, fluorescein angiography has a role in early papilledema to pick up if nothing else can pick up. But understanding the role of systemic investigations, including imaging techniques, so understanding the role of CT, MRI, ultrasound, know what to test when so that diseases are not missed. When an MRI is indicated, a CT would be a poor replacement. And if you're looking at trauma and fractures, an MRI is a poor replacement for CT. So understanding each role is key in residents to understand how they can manage later. Vascular imaging like CTA, MRA, or MRV in IIH. Functional imaging has now become very important, like fMRI, PET, SPECT, and of course, understanding when to do blood workups. Nonsensical, vast blood tests do not give us any information. So neuroimaging actually needs to be understood what investigation to order when. So if there is a field defect that is retrochiasmal, an MRI, an urgent MRI, informing the radiologist where to localize the lesion. And optic neuritis, whether it's NMO, whether optic neuritis, whether MOG, so blood tests supplemented by appropriate neurological investigations. All these things become very important. And of course, the other important thing that we need to talk about to residents to acquaint them are the massive fellowship opportunities in neuro-ophthalmology nationally and internationally. Now, there are a lot of centers providing neuro-ophthalmology training in India, and internationally, neuro-ophthalmology is a very easy to get fellowship for research and for clinical purposes. It, of course, gives us the advantage of having multi-speciality interaction. So people who would eventually want to work in multi-speciality, even private hospitals or corporate hospitals, it is a very added benefit to work with. And of course, your practice can get added with interactions with pediatric ophthalmologists, strabismologists, pediatricians, orbit and comprehensive ophthalmology. So you could co-practice neuro-ophthalmology with any of these specialties. So it's important that neuro-ophthalmology, which is now an increasingly important developing subspecialty, to acquaint the residents and make them into a better way to manage these patients, which are now increasingly being referred to ophthalmologists. Thank you very much for the opportunity and for listening.
That was a great presentation, Dr. Rohit. Excellent. I would like to ask you a question, but before that, a very warm welcome to our expert panel, Dr. Devin Tuli sir, Dr. Ashish Vaidya, Dr. Suchi Smita. Thank you so much for joining us. I would like to ask you one thing. What is the difference have you found in the kind of training in neuro-ophthalmology that we have to our postgraduates today and what it was, say, 10 years ago?
So there is an actually huge difference that is happening now. I mean, when I did my residency, or even for the over the little before the last 10 to 15 years, neuro-ophthalmology was never recognized as a separate specialty which requires any form of training. So as we are now developing, there are fellowships that are there and very clear diseases that come under the domain of neuro-ophthalmology. Earlier, anything behind the lens is the field of the retina guy, and if he doesn't understand what's there in the retina, then that's it.
Yes, but I would also like to have the opinion of our panelists. Dr. Devin Tuli sir, your special comments, please.
Yeah, I think it's a lot changed, and we must express our thanks to RT Center, which has been the pallbearer in North India, and of course there are good centers in South India. So more people, I think, Rohit, you can correct me if I'm wrong, but there's a separate society for neuro-ophthalmology for the last 3 years. Is that correct?
Yes. Thank you for
so
that everybody.
Shows,
thank you very much.
Yeah, that just shows how important the thing is, and there are a lot of fellowships happening across India. I know one of our colleagues from Maulana Azad College, he went abroad to do a fellowship because there was none available. Say this was about 20 years back. So there's a lot changed, and for the good. A lot less misdiagnosis between glaucoma and neuro-ophthalmology. That is my line, so I can say that.
Dr. Suchi Smita, a quick comment on this?
I think it's a great talk and really emphasizing the importance of this field, because most of us who are into general, also for us, it is good to brush up on these skills and time to time train ourselves in this aspect, sir. Great talk.
Dr. Ashish, being a vitreoretinal surgeon, there may be many times there's been an overlap with retinal pathologies and with optic nerve pathologies and neuroophthalmology. So what is your take on this, and how were you as a resident, what was your experience in neuroophthalmology?
Yeah, I think, Anaga, we were together in Sion Hospital, and I think we had quite a bit of experience in neuroophthalmology. The basic reason was also because Sion was a trauma center. And if you remember that there would be a lot of trauma cases which you would see, especially, orbital fractures and things like that. Otherwise, also we had a full-fledged neurology department and a neurosurgery department. So the exposure at that time was definitely quite good.